Hospital planning has changed radically in the last 20 years, and I've been part of that process during that entire time. Before that period, really, planning followed a series of guidelines, many of which were dictated by the federal government, by other groups of legislators that said this is what a hospital is and this is what a hospital should be. And planners really came into hospitals and said, we're going to build this for you. This is what we do. We know what we're doing. And it was a fairly set, cut and dry kind of process. Then about 20 years ago, a revolution happened. And that revolution really was through a very influential group of people, mostly in the environment of pediatric care. But they said, you know, this should not really be legislative or physician or administrative directive processes, that planning really should be focused first and foremost on the patient and the family. So these groups have been very influential in starting these processes and changes, but what it really allowed us to do is go in and begin to look at planning from the perspective of both the providers, users, and the recipients of that care. A new hospital was needed at Stanford for a number of reasons. The first and foremost of which was a legislative reason in the state of California. We had new legislation to provide hospitals that met certain new seismic standards for safety. And very simply what that meant is before these standards, hospitals had to meet what was called a safe building standard, meaning after an earthquake, the building stood up. What we found, though, with those standards is the buildings did not collapse. There were no deaths involved in the earthquakes during the late 1980s, but a number of those hospitals became non-operational. So we had these buildings, but we didn't have the ability to provide care in those buildings. In certain hospitals in Southern California, that lasted up to a year, where there was no patient care in hospitals because of the damage that was done to the buildings provided. So the state of California passed legislation that said hospitals have to meet a higher standard of safety, meaning they needed to be operational during and directly after the earthquakes. This is a very, very different building type. A lot more structure involved, much more steel cost in the basic organization of the building. So this became a very big issue of how to do this. A lot of people heard this as sort of retrofitting of buildings. But as you can imagine, if you have an older building and you have to strengthen that building structure, you have to get to the structure, which means you have to close the building, demolish portions of the building to get to the structure to strengthen it, and then rebuild those elements of the building. Well, in a hospital, that doesn't work because the hospital would be closed during the retrofit to seismically strengthen the building. So most of the hospitals in California have responded to this by building new buildings, which is what we're doing here at Stanford. We have some buildings on our campus that meet current seismic codes that were built in the 1980s, but our original buildings here at Stanford, built in the 1950s, do not meet those standards, and we have to replace those beds, which is about 150 beds within our complex currently. But we're also growing as an institution, so we need additional beds. And besides that, the size and the organization of the designs of the buildings we have currently really don't meet our requirements, especially in areas that have had very significant technological advances. So areas such as operating rooms, intensive care units, our emergency department. These highly technical areas really need to be redeveloped here at Stanford to meet current seismic standards, to meet current operational standards, and to frankly surpass those standards so that we can be really one of the truly great international medical centers.